Welcome to Brain Wellness, the podcast. I'm your host, Mandi NP. Each episode will bring you a new topic or interview related to brain health and wellness as part of my mission to help you on the path to a healthier, happier brain. So, let's get started. Hello, everyone, and welcome back to another episode of Brain Wellness, the podcast. Mandi Dickey, solo here today, again, doing another one of the ABCs of concussion episodes. We are on to letter E already. It feels like just not that long ago that I started this series, but here we are on letter E, several letters in. As with the previous episodes of the ABCs of concussion, all of today's words will start with a letter of choice for these episodes. And they all relate to something that either people with concussion experience, a symptom, or a problem that they face, or something that just really hits home for the community of those with concussion and TBI. So again, as with every previous episode, I've always mentioned too that if you are somebody or you know somebody who has symptoms that just aren't really well diagnosed, concussion is probably one of the most common misdiagnosed or missed diagnoses out there. So if you have symptoms or you know someone who has symptoms that just haven't gotten diagnosed, and I cover those symptoms in one of these conversations, it might be a time to go back and look and see, when did those symptoms start compared to, was there an episode or an event that occurred that may have caused a head injury that could have triggered off these symptoms? Because I have seen that on multiple occasions now, dealing with clients and now patients, again, like looking at what all they're dealing with as far as long-term problems related to a concussion. So leading us off today is, in our letter E, is emergencies. And this is one that I've kind of covered a little bit in previous episodes already also. But when we think about emergencies in terms of concussions, we're looking at what do we need to evaluate immediately to prevent having a bigger problem go on, or to try to identify a bigger problem than just, I say just in quotations, just a concussion. So the main concern for concussion is a head bleed. So when we're talking about emergency situations, we're looking at symptoms that might be symptoms of a head bleed. So the more serious form of concussion or TBI. So symptoms that require emergency treatment or emergency evaluation would include the following: any or all of the following. It doesn't have to be all of them. You could have some of these or just one of these after an accident where you hit your head or where you hit your torso hard enough to cause your brain to slosh back and forth inside your head. Remember, you don't have to hit your head to have a concussion. So any of these symptoms can come on, even if you just had a hit to the torso, you didn't actually hit your head. And again, remember, you don't have to lose consciousness. So we've already covered those topics. Don't have to lose consciousness. However, symptoms that would be emergency situations where you should really get to the emergency room, at a minimum urgent care to get evaluated after a concussion. If you do have a loss of consciousness, especially if it's more than 1 minute, or you have the inability to wake up or stay awake, those would be concerns that there might be excess swelling on the brain, such as potentially with a bleed into the brain. Seizures after a head injury would be an emergency situation. Confusion, the increasing confusion or the inability again to stay awake, or unusual behavior. Also signs of confusion with that. Headache that is severe or increasing and does not go away. If you have a headache and it's tapering off and it's going away, fine. Probably most people are going to have somewhat of a headache after they have a head injury, but that headache that gets more severe, it's increasing in intensity, that's a sign that you need to get that evaluated. Repeated vomiting. If you hit your head, you get nauseous and you're vomiting repeatedly. Again, another reason to get in and get evaluation, because there could be a potential bleed happening into your brain. Double vision or loss of vision, one pupil that's larger than the other. And I will say that kind of tongue in cheek with that a little bit, because my entire childhood growing up, I had one pupil that was larger than the other because my prescriptions were so different. But if people aren't aware that they have that, and now they have that after a head injury, that would be something to get evaluated. Any weakness or tingling or burning in the arms or legs, again, could be a symptom of increasing pressure in the brain, potentially bleed onto the brain. balance problems or walking problems, slurred speech, clear fluid draining from the nose or ears, because that could mean you now have a cerebrospinal fluid leak. And of course, visual deformity of the skull. So if you can visibly see that somebody's skull is deformed after a head injury, probably should get that evaluated in the emergency room. That's not an urgent care type of situation. So in the case of these emergencies, you absolutely should get evaluated. We've talked about the whole story of whether or not somebody can fall asleep or take a nap after a head injury. And if they've had these severe symptoms, you want to get them evaluated before allowing them to sleep, because the biggest risk is that they then won't wake up if they have had a bleed, or you can't wake them up and you can't get a good evaluation on them. So sleeping is okay, but we really, if they have any of these severe symptoms, they should get evaluated first. What happens from there? I can tell you that not every emergency situation is going to be the same for every patient. Not every patient is going to get the 100% best care that they possibly could have. When I was in my car accident and I went to the emergency room, I had some of these symptoms, went to the emergency room. They got a head CT, which was negative, of course, because I didn't have bleeding into my brain, but nobody ever from the emergency room told me I had a concussion. That's something that we need to work on, and that's going to come up in one of my letters later on in the conversation today. The next conversation that I want to have is about employment. So another E letter, employment. Employment, getting a job, the ability to get a job, the ability to return to your job after your injury can be very difficult. There are multiple different impairments. They can be cognitive impairments, physical, emotional, behavior impairments. Any of those, or any or all of those, can make it difficult to get back to work or to get to any kind of work after you have a head injury. There are various environmental barriers. There could be stairs or long corridors, long hallways that people have to walk, and now they have exercise or activity intolerance and they can't tolerate those stairs, or they have a physical injury that they can't do those stairs. Stairs make them lightheaded. That could be a problem also. Lack of transportation, especially if people have visual difficulties or cognitive difficulties that are preventing them from driving, they might not be able to get to work. So that might be a big barrier right there. And then other people's attitudes. When I say that, I'm talking about anybody else's attitudes toward the person that has the injury, because again, as we've talked about in multiple other episodes, brain injury is an invisible disability. People can't see that you're having problems. You look just fine. Most people that look at me do not know that I've had a brain injury because I don't look like anything is wrong with me. But that said, if I stutter, if I can't come up with a word, if I get angry about something, or any of the other symptoms that we're talking about, people might look at that person funny, or they might have certain feelings about that person and maybe think that they're lazy or that they don't want to do their job, when that can be a real hindrance to the person that's trying to get back to work. They're working hard to try to get better, to try to get back to work, and they have all these negative feelings coming from outside that can hinder that and can make them feel bad about themselves. And that can actually deteriorate their healing process. Also, it makes it difficult to try to heal when you're constantly trying to fight out this barrage of negative feelings from other people. Some people might require accommodations in order to get back to work. The American with Disabilities Act does provide some protection for that. It requires that employers provide reasonable accommodations to the employee to get back to work. The problem with this is that every employer has the right to decide what is reasonable and what is not reasonable. When I first was getting the okay to try to go back to work within several months of my accident, my neurologist wanted me to go back at 2 hours at a time, which some employers can accommodate that and some can't. Mine could not. So that was a deterrent for me to try to get back to work at that point, because my employer could not accommodate the 2 hour time frame. We would just be getting into the busyness of my work when I would have to stop and then leave. So my employer could not accommodate that. It was not a reasonable accommodation for them to try to make. Other accommodations that might be recommended, other than just those shorter days, they might include more frequent rest breaks. They might include either a later start time or earlier leaving, transferring to a different position, for a short period of time to allow the person to heal before they get back to something, especially if something is in a high risk area where they're high risk of falling or getting another injury. It's really important for them to maybe take a step back from that particular scenario until they are in a better place to get back to that job. Reduced screen time. So many of our jobs are on the computer these days. Just being on that computer can be really hard for somebody's brain who's trying to recover. So reduced screen time might be required. Reduced driving or physical activity, again, depending on the job itself. And then either limited or no use of machinery or heavy equipment while the person is trying to heal. It could be too loud for them. It could be too overstimulating. They might be still taking pain medications where they can't operate heavy machinery. There's so many different factors that go into that, which might lead to these accommodations being listed by the provider as something that the patient has to then follow when they go back as an employee back to work. And again, it's up to the employer to decide if these are reasonable accommodations that they can make in their work setting. Other accommodations could include use of assistive technology, such as screen readers or magnifying software or Dragon devices for typing. So if you are better with your words than you have with coordination with your fingers, and your speed of language is faster than your typing, that also might be helpful. Access to sunglasses, earplugs, headphones, especially for those that are bothered by light or noise, might be good accommodations that might need to be made for those individuals trying to get back to their jobs. For any position, it is recommended to start gradually. If you try to go back too soon, too fast, too long of days, too many days in a row, you can get burned out. You start having symptoms again. You start going backwards in your recovery plan. So if at all possible, trying to return at a part-time status and then increasing your hours as able, such as from going back at 2-hour increments, 4 hours, 6 hour, and then back up to 8 hours or 10 hours, whatever your normal workday is, or working from home if possible. If you have a job that allows you to do that, that's a great way to try to get back into some of that work on your own time when you don't have the high stress situation around you, all the stimulation from that workplace. Again, rest breaks, shorter work days might be beneficial. You might need to use short-term disability or long-term disability or things like FMLA, which is the Federal Medical Leave Act. That Federal Family Medical Leave Act is a benefit to employees that have been in their jobs typically for 1 year or more. So if you are employed for less than a year, you won't qualify for that FMLA. So as you're taking care of patients that might have concussion or TBI, and you're wondering why they're having so much difficulty with their employer, if they've been there less than a year, they don't qualify for FMLA. Their job is not protected legally at that federal level. Short-term disability, long-term disability would be potentially their only other options if their employer will grant that short-term or long-term disability, because I've heard stories of other people who have had concussions and traumatic brain injuries that their employers did not grant them that disability because they had not been there a long enough period of time. I was lucky enough that I worked for a phenomenal employer who granted my short-term and long-term disability to allow me time to heal. Beyond that, there are vocational rehab services typically offered through the county or through the state, and these are funded by both state and federal government. So not sure with our current government status, the livability of these programs, if they will continue on or if those will be unfortunately part of the cuts. I will be in DC actually next week, so I will be doing some lobby, hopefully to help preserve these resources that we have for people with concussion and TBI. These impairments are often invisible, so they can, as we talked about so many times, they are invisible impairments, then it's an invisible disability. So sometimes as you try to get into these vocational rehab services, you need to get evaluated by a rehab physician and or neuropsychiatrist to help to prove that you have impairments from that brain injury that meet the criteria for admission to that vocational rehab program. I hate anything that, I guess I shouldn't say hate. I strongly dislike anything that requires somebody to prove that they have a disability and prove that they have these impairments from a brain injury, but just because it's an invisible disability does not mean it is not real. And I have heard so many horror stories from people that were not believed and were told that they were faking things when they were seriously troubled by their brain injury. So unfortunately, this is another one of those programs that does require you to prove that you have impairments related to that brain injury that would help you meet the criteria for admission into that vocational rehab program. But they are out there, and their mission is to help people with brain injuries to get back into the workforce. So when we're looking at the research out there about people who get back into working after a head injury, there are some numbers that I saw that were a little bit different that kind of got me thinking, but then I kind of looked at it more and I realized what they're talking about. But in general, roughly 40% of individuals are stably employed even within 3 to 4 years after their injury. So 1, 2, 3, and 4 years after their injury, it went up from about 35 to about 40, 42% that are stably employed at that 3 to 4 year mark after their head injury. Another 23% were unstably employed. So the rest of that 20-some% is all unemployed that 2, 3, 4 years following their head injury still. So many people, this is still close to between a quarter and a third of all the people that have had a head injury or concussion or TBI that are still unemployed up to 4 years after their head injury. And looking at some of the factors that played into that, the ability to drive was strongly linked to stable employment. Again, we've talked about that. If people can't get to work, they can't get to that job. So if they can't drive, they can't get there. And looking at all the different research that was out there, this data remained very similar from 2003 all the way up to 2019. Nothing really changed in any of those studies that they looked at. In 2020, there was one PubMed article that noted 68% of those with moderate to severe injuries and 84% of those with mild injuries were back to work following a head injury. However, that said, it did not break it down to the stably employed and unstably employed as the previous research did. So I feel that the numbers are probably very, very similar because that 60 to 80% still adds up all of the percentages from previous of those that were stably and unstably employed, not to include those with the unemployment rate. So that last PubMed article from 2020 again noted that about 16% of those people had a complete return to their job by 12 months. So by the time a year had passed, only 16% had been completely restored to their prior jobs. 24% had accommodations still at 12 months, and 67% had reduced work hours or were less content with their jobs. That is a huge number of people who now have reduced work hours or are less content or even require accommodations in order to do their job to a satisfactory level. And of those that return to work, just under half of those actually return to their former jobs. So over half, slightly over half of people that have a head injury have to go back to a job that was not what they had prior to their injury. There was an article in 2022 that was published in the Journal of American Medical Association that took a deeper dive into the role of accommodations in getting people back to work. So how much did that accommodation allow people to get back to the workforce? And individuals that were not provided workplace assistance or paid leave resulted in decreased annual income. And then they kind of substantiated from that there was financial instability that can cause persistence of the post-injury physical and psychological symptoms. So those financial difficulties cause problems with patients. It causes problems with their mental health so that they cannot get back to work because of all of those symptoms. Without proper education and follow-up, individuals with so-called mild TBIs have increased risk for seclusion, misinformation, negative feelings surrounding their condition, and that enables those post-concussion symptoms to persist. So again, all of these factors come into play when we're talking about whether or not people can get back into the workforce after their injuries. Little shift in gear. Let's talk about the next E letter, energy. And energy, when we talk about that, there's a general decrease in both physical and cognitive energy after a head injury. So we see that people get both fatigued physically from physical activity, that activity intolerance that we talked about previously, and then that cognitive fatigue. The more they have to think, the more they have to use their brain, the more tired they get. So again, we talked about this back in the A letter with activity intolerance. When we talk about energy, we talk about just that feeling of being tired, feeling weak, feeling exhausted, even after minimal activity, meaning you get up, you get dressed, you get up, take a shower, you get dressed, you're tired, you take a nap. Literally very little activity required to cause this physical and cognitive fatigue. When you get cognitively and or physically fatigued, you get irritable, you get upset. It leads to headaches. It leads to increased forgetfulness, worsening of symptoms. That's when I call it hitting my wall. That cognitive fatigue gives you trouble with concentrating or thinking clearly. You tend to make more mistakes, whether it's taking your medications, cooking food, then incorrectly, burning food. You have difficulty finding your words. All of these can happen when your brain is tired because it's kind of telling you, I've had enough. I can't do anymore. I have met my limit for the day. Some of the best things that you can do is conservation of your energy. So taking regular breaks, taking breaks before you think you need them, because if you wait until you need them, you've already hit that wall and it's going to take you longer to recover. Take little breaks more frequently than you think you need them, and then you'll be able to go on longer. Plan and prioritize how you're going to use your energy. If you are a list person like me, make your list of a few things that you want to get done in a day, just a few. This is not an exhaustive list of everything that needs to get done in your house because you're not going to get to all of that today, tomorrow, this week, next week, whatever. It's going to take a while. So plan and prioritize your time. Make a list of a few things that you need to get done in that day. Prioritize which one of those things needs to take more precedence, and then do them in spurts. Do a little bit at a time. Don't try to get that whole list done before lunch. Not going to happen. It just doesn't get you there. Other ways to try to conserve your energy, identify those triggers that make you hit your wall faster. What puts you over the edge? Can you walk a mile, but you can't do a mile and a half? Identify those triggers, work within those limitations. Those are your current limitations. That's where you are right now. This does not mean this is what you're going to be like forever. This is just what you are right now. Work within those limitations, and you can gradually increase as your tolerance increases. Light exercise can actually help speed up recovery. So again, years ago, we used to tell people, lay low until your symptoms clear, but that really doesn't work anymore. So that light exercise can actually speed up your recovery, and it's good for you, but too much can slow it down. So you can still do too much of a good thing. You don't need to push yourself to the point of exhaustion. You don't need to push yourself to the point where you feel like you have to do high intensity workouts, for example. Now is not the time to start a HIIT training program. Now is the time to start slow and work your way up. You are a turtle. This is the tortoise and the hare race. This is not the hare sprinting, taking naps. This is you slow and steady wins that race. Okay. Work on improving your sleep because sleep is number one for brain healing. It has been proven time and time again that when we sleep, that's when our brain detoxifies our body from all of those toxins that build up in our brain throughout the day. All of the memories that we have thought about, everything that we've thought about all day long. When we get into that REM sleep and the deep sleep stages going back and forth, that's when we actually purge the toxins and all of those memories get stored. So I always use the example of the movie Inside Out. If you've seen that movie, you know what I'm talking about. In Inside Out, they have all these marbles are created. So every time you have an experience or something, a marble is created and it's a certain color. At night, they push the little button and all of these marbles go to where they're supposed to go. Some of them go into long-term memory, some go into short-term memory, and some of them get discarded because not everything that we do in a day is going to be stored in our long-term memory. But we need to get to that good sleep stage in order for the marbles to get where they're supposed to go. So we can't file anything into long-term memory if we're not sleeping well. We can't get rid of the toxins in our brain if we're not sleeping well. That will slow down your recovery. It will slow down your progression if you're not sleeping well. So sleep should be number one. And I will tell you, I thought for the longest time I did not want to take a sleeping medication. I finally gave in and did melatonin because I'm really sensitive to side effects. So I don't like to do a lot of prescription medications. Melatonin works really well for me. I know it doesn't work for everybody. When I had my talk with Dr. Schaller a few weeks ago, he was talking about how it's really important for people to get sleep. And these medications that we use are not going to be long term. So you have to remember that part too. There are lots of different treatments that we can do. If a medication is indicated in your particular situation, it doesn't have to be long term, but you do need to get sleep. So whatever we can do to get you there, it's going to be really very important. I will go more into this topic in the letter F episode, which will be our next one of the ABCs when we talk about fatigue. But I just kind of wanted to get the tip of the iceberg out there and just talk about that energy a little bit because there's so much that we can do to try to improve it. The next one kind of related to that is exercise. So exercise, again, we used to say no physical activity until symptoms went away, but 30% of patients have persistent post-concussive symptoms. And we now know that the longer you rest, the longer you stay away from activity, the longer it takes to get back into it. It does become harder to restart those activities. There is no good evidence to support holding off on activity until symptoms resolve anymore. So no good evidence to support that. There is a lot of evidence to support exercise as speeding up recovery. So again, you don't want to jump in too quickly. You need to slowly increase activity as tolerated. You want to avoid any strenuous activity or contact sports until you're cleared. So if you are an athlete and you had a concussion in your sport, you need to be cleared by an athletic trainer, by your provider before you go back. You need to, if you've done the impact testing, you need to repeat that impact testing. Make sure that you are cognitively ready to get back in the game because there are consequences of having a second concussion after that first one if you're still not healed. It's a whole nother different topic, but just to throw that out there, you don't want to get back into those contact sports too soon. That said, if you are increasing your activities as tolerated as you should be, gradually increasing them, stop and rest if your symptoms get worse. If you have headache, dizziness, nausea, confusion, stop and rest, start back up again. Don't push yourself and try to push through those symptoms because it's not going to get any better as you push harder. It's like pushing against a brick wall. Does that brick wall ever give? No, it's not going to give. Those symptoms aren't going to stop if you try to keep pushing through them. So the goal of trying to increase your tolerance with activities is not to push yourself past the point where you're feeling like crud now. It's to get yourself up to that point and then rest. Keep going up to that point until that point moves forward a little bit. It will gradually move forward as you slowly increase your activity and you build up that tolerance and you build up that resistance so that you can do those activities for a little bit longer, a little bit harder, a little bit stronger. You can do all those things. And as you're feeling better, your workouts will get easier and you will get better. Listen to your body. That's a big thing that we have talked about so many times on this show with various individuals that have come on. You have to learn to listen to your body because if you don't stop and listen, you won't catch those signals on when you need to take it easy, when you need to rest, when you need to slow down. You won't catch those symptoms of a little bit of headache or a little bit of tiredness before you hit your wall. I'm still not really good at finding those symptoms before I hit my wall. If my husband's there, he can find it. But that's not him listening to my body. That's just him watching my body language because apparently there's body language that I can't feel that's happening when I hit that wall. But I am definitely better at listening to my body now. When my kids go to sleep, I get ready for bed too. I don't try to tough it out and stay up longer because as much as I would love that little bit of adult time, sitting up watching TV with my husband or just hanging out, we go to bed, we talk for a little bit as we fall asleep. So we both have have taken on that priority of sleep as something that's really absolutely necessary. Exercise is there too, but listen to your body. You have to listen to your body and know when you need to rest. Exercise intolerance can actually be related to the autonomic nervous system dysfunction. We've talked about that. We talked about some of that back in the A letter as well with that autonomic nervous system. An interesting thing that I saw on this is that when that autonomic nervous system is not working properly, your ventilation becomes low, meaning you're not breathing as you should be. You're not ventilating, you're not getting enough oxygen into your body. It leads to rising arterial levels of carbon dioxide. So, if you'll recall, carbon dioxide and oxygen are two main gases in our blood and in our air. We need that oxygen in our blood so that it can get through the bloodstream, get out to all of our organs and oxygenate our body, our muscles, everything, so that our brain, so that we can think and that we can function. Carbon dioxide, when there's too much carbon dioxide, that builds up on our body and it makes it difficult for us to move. It makes us very sluggish. It limits our exercise performance. So this is why things like hyperbaric oxygen therapy and exercise with oxygen therapy are proving beneficial. Both of these treatments increase your blood oxygen levels, which is promoting brain repair. I remember learning about hyperbaric oxygen in nursing school, and then I really never saw it again because it was not offered at any place that I worked. I have had an experience with exercise with oxygen therapy at Hypercharge, and it was phenomenal. When I was able to add that exercise, it was a whole new level of healing again for my body because I was getting that hyperoxygenated air into my bloodstream, into my lungs, up to my brain, and helping my brain repair. There are facilities that are using hyperbaric oxygen for this same purpose, to increase the blood flow to the brain, increase that cellular capacity, increase your cerebral blood flow, your brain blood flow, so that you have good oxygen going to your brain so that you can heal. So both of these therapies would be beneficial on helping out your brain to recover, helping with that exercise tolerance after a concussion or TBI. So super cool, really neat research that's coming out on these different therapies. Another E topic is EMDR. I've kind of suggested this in previous episodes. So EMDR stands for the eye movement desensitization and reprocessing. This is a specific type of therapy for somebody, especially with PTSD. So you talk about a traumatic event. You talk about the feelings surrounding the traumatic event. So not necessarily going into extreme detail about the event itself. You give a few details, but you're more talking about how you felt about it, the emotions, you identify the feelings with it, while you're moving your eyes either side to side, watching a light in front of you, or engaging in something that your therapist is holding in front of you, or doing some sort of bilateral stimulation. The aim with EMDR is to change how your memory has stored in that brain of yours. So how did you store the memory of that trauma into your brain? Again, you can get significant relief of PTSD symptoms, PTSD meaning, again, post-traumatic stress disorder. It can happen from a physical trauma. It can happen from an emotional trauma. Here, we're talking about it more specifically with the concussion. So athletes can have issues with PTSD after having a really bad concussion in their sport. People that have been in motor vehicle accidents can have PTSD because of the motor vehicle accident itself. That was one of the issues that I had, was PTSD related to the car accident. And I couldn't go through the intersection where I had the accident for quite some time without having a panic attack. I couldn't see an emergency vehicle going on the road with or without its lights on. I couldn't drive by an accident without having a panic attack. So it's a significant issue that actually slows down your healing process. So this is one of the most researched and used methods of treating trauma out there. I've talked to lots of different people on this show about different ways to treat trauma. EMDR is one of the most researched and one of the most used methods. Naturally in our body, we have this natural information processing that occurs during our REM sleep. Again, the importance of REM sleep. But we have this normal processing that goes on during that REM sleep. It gets interrupted when somebody has a traumatic event, and it gets trapped in the limbic system in the body. That's where our emotions are stored. because of this, because of that trapping, we develop maladaptive processes, meaning we have processes that are not beneficial to us, and that trauma can be reinforced through other events that are similar in nature and can be triggering events. So we work on this through dual attention or dual stimulation, bilateral stimulation. So dual attention is when you're watching either the practitioner's hand movements in front of you or a moving light. At first, we could not do that with me because I had so many visual issues going on. You can also listen to audio stimulation or do tapping on your shoulders or on your legs. So you're actually physically tapping on your own body bilaterally. So you're doing kind of a tap, 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 tap on one side, then the other really fairly quickly. This mimics that natural information processing that occurs during REM sleep. So by doing this, by watching the visual stimulation or tapping on your body, you're mimicking that natural processing that occurs or that is supposed to occur when you're in REM sleep. But again, because of what's happened with your brain, you are no longer doing that appropriately during REM sleep after a brain injury. So because it mimics that natural processing, that's what makes this so much more effective than just talk therapy by itself. So it does not require a lot of verbal narrative around the trauma. You can go into some detail, whatever you feel comfortable with, but more of it is related to the emotions involved. So some very powerful emotions can be released during these therapy sessions. So it requires a lot of preparation and frequent reevaluations with your therapist. So you really have to do a lot of prep work. You don't just go into the therapist's office and jump right into EMDR. You literally go in, you do the intake process, you set up your history, get that intake completed, and then you create a mental safe space. So with me, I had to create a mental safe space so that if the experience from the traumatic event got to be too much at any point, we could stop. And my therapist would ask me to go to my mental safe space. I would go, it was in the woods at my favorite camping location. That was my safe space. So I could go there and all of my symptoms would calm back down again. So it does require a lot of preparation. It requires you to understand the possibility that these deep emotions can come up. So there has to be that understanding. And it needs to be done with a trained therapist, somebody who is certified to do EMDR. That would be the best bet that you have, and it can be very effective when done over a matter of months. It is not an overnight fix. It is a slow process to get you there. But I tell you what, when I got to the point where I was graduating from my EMDR therapy, I could drive down the road as if it was prior to my accident, and emergency vehicles could go by, not a problem. I could see an accident, not a problem. I can go through that intersection, stop at that intersection at that stoplight, not a problem. No issues whatsoever. It was back to my normal state, and it was so freeing to not have to have that problem anymore. And then you know what else happened? I started getting better again. So I had been sitting at a plateau for a little bit, and I started to improve because that PTSD barrier was gone. So really, really important to address that part of recovery so that your brain can fully recover to its best ability. The next couple topics are, again, kind of related to each other with our emotions, but the first one is empathy. So empathy is that ability to understand other people's feelings, emotions. When you have damage to the frontal lobe, especially, that can cause lack of empathy to occur after a brain injury. There are disrupted neural pathways. So the information processing from that frontal lobe of your brain, again, the frontal lobe is literally in front of the front of your brain. That information needs to be processed and passed through your brain to other areas so that you can understand feelings, emotions, words, sarcasm, humor, all of those things. So when you have damage, especially to that frontal lobe, there are other areas in the brain that can affect it as well, but that's the most common. You can have trouble recognizing and understanding how others are feeling. You can have troubles understanding sarcasm, understanding jokes, humor, happiness even. You just have overall difficulty accurately interpreting facial expressions of other people, body language, emotional tones. So understanding when somebody is speaking out of fear or anger or happiness. There was a comparison study of TBI patients to controls with a psychological evaluation and EMG both. So they looked at the psychologically how people would interpret the emotions that they were being shown. And EMG looked at the physical response, the body's physical response to whether or not they understood what they were seeing. The TBI group in this particular study showed a reduction in the ability to empathize emotionally, and they had reduced physiological response with exposure to angry faces, meaning there was no EMG changes to identify that they even recognized that that face that they were being presented with was an angry face. So that ability to understand those emotions that were being expressed to them was definitely decreased. This can lead to impaired social functioning. So in a social situation, when you're around friends, family, at an event, you need to be able to understand what people are saying, feeling, doing around you so that you can respond appropriately. This is where we see some people that are responding with inappropriate responses to whatever emotions they see. They're laughing at inappropriate times, crying at inappropriate times. That can be something else as well, but it can also be just that lack of feeling because they're not interpreting what you're saying, what you're showing, so they have just a lack of emotion. There was another study that evaluated the emotional empathy following a TBI and found a high frequency of low emotional empathy scores. So it was very common for people following a TBI to have low emotional empathy. And this had no comparison to or no relationship to severity of the injury or the neuropsychological performance of the individual with the TBI. So neuropsych, they could be doing just fine, but they emotionally couldn't understand what was being presented to them. Empathy can be rewired. That can be done through cognitive behavioral therapy, through mindfulness, through things like managing depression and anxiety, because that will take the edge off of some of those symptoms as well. So empathy, a big topic, kind of along the same notion as that is emotional dysregulation. And I kind of laughed with my husband with this one that how could I have almost forgotten this one as I was going through the E letters on here because it may or may not have been something that I have or still continue to experience. Emotional dysregulation just means that there's a potential for an increase in depression and anxiety. There can be a lot of mood swings, irritability, temper outbursts, and emotional lability. Being emotionally labile means that you can be happy one second and sad or pissed off the next. Literally that quickly. It doesn't take much to get those emotions changing. This can be due to adjustment in changes of independence, in changes in family roles, changes in society around you because of your injury, because of your invisible disability. All of this can cause emotional distress for the person experiencing the TBI, which then can lead to emotional distress in family or caregivers because of these difficulties regulating their emotions, because of difficulties with empathy as well. People with depression and anxiety prior to an injury may actually experience worsened symptoms after a TBI, and TBI coupled with PTSD can lead to poor cognitive and affective outcomes following a TBI, meaning their personality can change, their cognition can be different following a TBI if they have a TBI and PTSD together, which is why when I talked about the EMDR, it's so important to get that PTSD treated. How do we deal with somebody with emotional dysregulation? You can do psychotherapy with or without EMDR. Either way can be helpful, but again, if there's that PTSD role, you really want to include the EMDR. Mood stabilizing medications can be helpful even for a short period of time to get through people through a time when they're working with a therapist. So all of the above were helpful for me. Maybe minus the stabilizing medications because I'm so sensitive to side effects that was not a good one for me. The last topic that I want to cover today, and again, there are so many more that I could have covered, but I didn't want this to be another one of those really super long episodes. So the last topic for today is education. And this one I want to cover on different levels. So I want to cover education to the patient, education to the public, and education for healthcare providers, healthcare personnel. So to the patient, things that I want to educate you on. So if we're talking about educating the patient, this would be maybe for the providers also. Um, when we're talking about educating the patient, we need to educate patients where they are at cognitively. So educate to their current level, not to what they were prior to their injury, but to their current level. My neurological chiropractor had me record him. So take out my phone and actually take video of him when he was giving me directions on the exercises that he wanted me to work on. He's done that every time he's given me new exercises, and this was brilliant. I wish that every provider would have done this all the way along because it was amazing. After I was done working with him, then I was able to sit down, watch the video again, take notes on it again, write down what he wanted me to do. And if I didn't remember something from my notes, I could go back to that video and watch it again because it was brief. It was something that I could just easily look for on my phone, find that video, and look at those recommendations that he was giving me again and follow the exercises exactly as he wanted me to do them. So that is something that I plan on utilizing in my concussion clinic as well, is that need to be open to having patients and families take video so they can refer back to it later. So one of the things that I want to do when I'm done seeing my patients then at the end of our appointment is having them take out their phones if they have them and say, okay, now take a quick little video of me giving you these instructions so that you have that. Because it's great to give things in writing, but if people are having difficulties comprehending what they're reading, the written instructions are not going to be helpful. So if you are giving written instructions, give them in bullet points rather than paragraphs or really thick booklets, because with cognitive difficulties, again, it's hard to follow lengthy written materials. I did much better, and I still do much better actually with bullet points than I do with long written information because it's just really hard to follow. I was given pamphlets from the Brain Injury Alliance, and I was so glad to get something, but I immediately handed them to my husband. And I said that he was going to need to help me with those because I couldn't comprehend what I was reading at that point. So pamphlets, booklets are great if you're giving them to the family members of somebody with a TBI. But if you're giving information to the person with the brain injury, bullet points, short, brief information is much, much better. And then again, visual, that video would be even so much better. Be ready to repeat information. Saying it once likely isn't going to stick. So send the patient home with clear, concise instructions rather than just verbally saying things to them. And then again, be ready that if they come next time, they're going to have similar questions again. I asked the same questions over and over and over again. I got to the point where I was telling the same stories over and over. My kids would laugh at me because I couldn't remember that I'd told them that already. So repetition is key. The more you hear things, the more it's likely to stick as well. Education to the public. We need to educate the public on what a concussion actually looks like. So people typically know the common symptoms of headache, maybe nausea and vomiting. People generally think of loss of consciousness, but they don't think of some of the other things like mood changes, sleep disturbance, emotional dysregulation, sensory alterations, all of these things that can happen, blurred vision, double vision, troubles with speech, word finding. All of those are things that can happen with a concussion, and we need to be aware of those things. We also need to be educating the public on the consequences of not treating concussions appropriately, which we've talked about on this show previous times. Also, if we don't treat them appropriately, we're going to have long-term consequences in individuals that have concussion, and that can lead to social problems for their family, for society in general. If people are leaving the workforce because of these brain injuries, how do they get to work? How do we have the resources to help them? Because not every place has the resources to help. And then educating the public on where to go for help, where to go for help. Where does the individual go? Where can family members go to find support to help their loved one? All of these things are things that we have to think about. And then we need to work on the stigma of admitting symptoms so that athletes don't feel the need to push themselves to go back too soon. They don't feel pressure from their parents, from their coaches to get back into their into their sport too soon, so that they end up with permanent brain damage because of multiple head injuries. So really, really important to allow people that time to have their brain heal before they get back into their activities so that they can function appropriately. And then finally, education to the healthcare providers. All healthcare providers need to be educated on the best evaluations for concussion, especially if they're working in emergency settings, urgent care, primary care offices, because those are typically the first line of defense. When somebody has a concussion, they're going to go to one of those three places first: urgent care, emergency, or their primary care, and say, hey, I think something happened, or maybe I just have these symptoms and I don't know what it's from. So we really need primary care, urgent care, and emergency room providers to be educated on the best evaluations for concussion. Dr. Schaller gave us a really good example a few weeks ago here when we talked about those evaluations, the VOMS exam especially, and really the importance of not skipping over this diagnosis. I have worked for many years in a hospital where neurology would get consulted. So I would go do a consult on a patient that was having neurological symptoms, and it turned out they were a trauma. They had a traumatic bleed, they had neurological symptoms, and nobody was really telling the patient why they had these neurological symptoms. Well, if you fall and you hit your head hard enough to cause a bleed, you're also going to have a concussion, and nobody had told the patient that they had a concussion. So I was going and doing consults and educating the patients on the fact that, yes, they had a concussion because they hit their head hard enough to cause a bleed. So we can't skip over this diagnosis. It's really important for people to know the full picture, what's exactly going on. So as that healthcare provider, you really need to be sure that you do that good exam, you get a really clear diagnosis, and you let the patient know. Don't just assume that they know that if they hit their head hard enough to get a bleed, that they're going to have a concussion. You need to be very obvious with that. As healthcare providers, we need to be updated and stay current on current recommendations rather than leaning on what we learned in school. Things have changed, and it may be a minute since you were in nurse practitioner school, nursing school, physical or medical school, PT school, OT, whatever. It may be a minute, hot minute since you've been in those courses, and things have changed in the protocols for treatments and management of concussion. And it's really, really important that we stay up to date on these things. One thing I have been kind of on a soapbox about lately is, as a healthcare provider, we have options when we are doing our continuing education credits to keep up our licenses. And I would encourage you as healthcare providers that are out there listening to look for something different than what you've always done. If every year you go to do your continuing education credits and you're looking for the newest, latest, greatest recommendations on blood pressure, that's all great and well and good, but that's not going to show you anything outside the box. So if you're always looking for the JNC recommendations on blood pressure management, you're always going to find the JNC recommendations on blood pressure management. You're not going to see the lifestyle recommendations, the outside the box thinking that could lead your patient down a different road, especially if there's someone that's really sensitive to medication side effects. That medication might not be the right one for your patient to begin with. So I urge you, I encourage you to look for something outside of what you normally do for your continuing education credits and educate yourself on something that you don't know much about. Look at these different complementary therapies and see if that's something that you might put in your toolbox for helping your patients in the future. And we really need to think big picture and think outside the box, outside our typical Western medicine toolbox, to think of other options for our patients. So the traditional PTOT speech approach might work for some people, but it's not going to work for everybody. So you need to have other things in your toolbox that you can offer to your patients to increase their chances of recovery and having a really meaningful recovery so they can get back to stable employment, as we've talked about this episode. So again, lots of really good topics today. If you do have more suggestions for the rest of the alphabet, the next one's coming up will be letter F, probably in about a month or so here. So F, And moving forward from the letter F and everything after that, I'm still open to suggestions. So if you have any suggestions, please send them my way. Otherwise, again, as it with the rest of the ABCs of concussion, if something resonated with you today, you can certainly leave me a comment on wherever you're listening to this podcast episode. Otherwise, I hope to see you next week for my next interview, because I've got some really good interviews coming up. Oh, and I would be remiss if I did not tell you that if you are local in the Minneapolis, especially Northwest Minneapolis area here in Minnesota, on Saturday, March 9th, I will be hosting a book signing event at Rock Elm Tavern in Plymouth, Minnesota here, where you can snag a signed copy of my book, Welcome Back, a TBI recovery story from provider to patient. I'm really excited to be partnering with Rock Elm for this. They're going to have some drink specials and things. I have an Eventbrite link. You can pick up a little general admission ticket and get yourself a specialty drink designed for the book signing event and some appetizers. And if you want to throw on a book, I will sign that for you the day of the event as well. So if you are local, that's really exciting news that I have for that one. Otherwise, thank you so much for being here, guys, and we will see you next time. Thanks for tuning in to this episode of Brain Wellness, the podcast. If you enjoyed this episode, I encourage you to subscribe, like, and share this with others to help me continue on with my mission to help people live healthier, happier lives. Go to www.brainwellnesssolutions.com to see what I'm up to and get links to all the social medias there. See you next time.